Okay, back to the CCRN review. A great topic, neuro. Here we go. They increased neuro on the exam. It only used to be 6% on the past exam. And now with the new exam that's out now, it's 12%. Therefore, you're going to see 18 little itty bitty baby questions. You're not going to have any problem with neuro whatsoever. I'll tell you exactly what you need to know. So let's go. Cerebral vascular accident. When someone has a CVA, it could either be due to a hemorrhagic event or an ischemic event. So the two causes of a CVA, cerebral vascular accident, can either be an ischemic event or a hemorrhagic event. Now, if you have a CVA, and that CVA is from an ischemic event or a hemorrhagic event, the end result will be either a TIA, an RIND, or a CI. So, a TIA, transient ischemic attack, right? TIA, transient ischemic attack. Someone has a stroke, 24 hours later, they're better. An RIND, a reversible ischemic neurological deficit. Reversible ischemic neurological deficit. It's just like a TIA. Same exact thing as a TIA, only it takes you about 3 months to get better. And then a CI, a cerebral infarct. We never used to have RINDs. The way I learned it was either you had a TIA or a stroke. That's the way it was. A TIA or a stroke. That's the way it was. But now they have RINDs. Like the guy across the street from me, he had a stroke. And he was all like this and everything. And then he went to PT and and like within 3 months, 4 months, he started walking with a walker, then a cane, and now he don't use anything. So everybody on the block says it was a miracle. See? Now maybe it was a miracle, but there's no reimbursement for miracles. That's why they call it an RIND. You get money on that one. So a RIND is a reversible ischemic neurological deficit. In other words, it's a long TIA. And then a cerebral infarct. When you have a stroke or a cerebral infarct, it could be due to a problem with the basilar vertebral artery, which is in the back, which you hate when that happens because that supplies your brainstem. And if you're lacking any blood to your brainstem, it's not good. And then some people can have a cerebral infarct involving the carotid arterial system. Those are the kind of strokes where they have a stroke on the left side, they get right-sided weakness, right-sided hemiparesis, right-sided hemiplegia, right-sided homonymous homoniopia. Homonymous homoniopia. That sounds like a Catholic thing too, right? And then you go vobiscum. Anyway, homonymous homoniopia. It's blindness in one half of both visual fields. Homonymous, homoni, half, opia, eye. Homonymous homoniopia. It's blindness in one half of both eyes. So if you have a left CVA, you get right-sided weakness, right-sided hemiplegia, plegia, paresis, and then 20% of people get that homonymous homoniopia, meaning they're blind in one half of their eyes. One half. And then their eyes always look to the boo-boo, right? Their eyes always look to the boo-boo. Hey, what's going on over here? Hey, I got right side weakness, right side hemiplegia, right side hemiparesis, right side homonymous homoniopia. And the thing is they're blind in this half, so when they look this way, because this is the strong muscles, these are the weak muscles. So the strong muscles pulls your eyes to look to the boo-boo. So now they're completely blind, right? Then the nurse comes in through the door with the food tray. Are you hungry? 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 So he hears something. He hears something. He thinks maybe it's over there. And then the next thing you know, the nurse gives it to the ward clerk because she thinks you're confused. Meanwhile, you're starving. So, anyway, so when you have an ischemic event or a hemorrhagic event, the end result will either be a TIA, an RIND, or a cerebral infarct. Now, when you have a cerebral vascular accident, whether it be a TIA, an RIND, or a CI, cerebral infarct, our goal is to decrease cerebral edema. That's what our goal is, to decrease your cerebral edema. Now, in my hospital, they got a different focus. Because, see, in my hospital, when you have a stroke and you come in, we keep you NPO. Oh, yeah. At least a day or two. We'd hate for you to stroke on Monday, choke on Tuesday. So we always keep you NPO. Now, whenever you keep the elderly NPO, even if it's only for a day or two, their protein levels start to drop. Once your protein levels drop, you lose your oncotic pressure, and fluid will start to shift down to your cell, into your brain cell. And then, since you're not eating, in my hospital, we give you D5W. So where's that bag going? In your head. Hey, Pop, what's up? You got yourself some cerebral edema? Come on over here. You ain't seen nothing yet. Going to keep you NPO for a day or two, let your protein levels drop so fluid shifts out to your already swollen cell. Then, see this bag of D5W? Going to be in your head by the morning. Then, as all this water shifts into your already swollen brain cell, you be moving the only side of your body that moves. You be moving out of the bed, in the bed, out of the bed, in the bed, out of the bed, in the bed. Maybe you'll be playing with your IV. So what am I going to do? Tie you up, because I won't want you to hurt yourself. Now, I'm going to tie up both sides. Even though this side is dead, I'm tying it up. Loosely. Because you never know when it might come alive, and I won't want you to hurt yourself. Now, you know whenever you apply pressure, right? You know whenever you got wrist restraint on somebody, and they pull up on that wrist restraint, they increase intracranial pressure 50 points. Then I would hate for you to get a decubitite ulcer, so I want to turn and position you every 2 hours. Well, I turn your head to the side like this, which increases your ICP by 20 points. You've been here for a day or two, should be able to find a pillow. Put your head on a pillow, which increases your ICP by 20 points. Then this is dead side, it's very heavy. So I'm going to kink your leg up like this. I'm going to flip you like this. I'm going to hang out like this for 2 hours. 2 hours later, hang out like this. Hey, Pop, what's up? You have yourself some cerebral edema? Come on in here. Going to make it really good for you now. Going to keep you NPO for a day or two. Let your protein levels drop so fluid shifts out into your already swollen cell. Then, see this bag of D5W? Going to be in your head by the morning. Then, to make sure you have intermittent intracranial pressure, I'll put a wrist restraint on you. And then, to make sure your pressure stays elevated at all times, I'm going to turn and position you 20, 40, 50, 90. Whoa! 2 hours later, flip you on the other side. Whoa! Not for nothing, he would have been better off on the kitchen floor where you found him. You know why? He would have been flat. He would have been flat. He would have been dehydrated. It would have been the best thing for him. But oh no, you had to bring him into the hospital. Okay, so these are all true stories. Okay, let's talk a little anatomy, because if you know anatomy, neuro is very, very easy. So here we go. We're going to talk about the brain. Ready? This is your brain, and this is your brain on drugs, okay? Now, top part of your head is called the cortex. You got a problem with the cortex, you decorticate, right? You got a problem with the cortex, you decorticate. You got a problem with the brain stem, and your brain stem either be the medulla, the midbrain, the pons, or the medulla. You got a problem with your brain stem being the midbrain, the pons, or the medulla, you're going to decerebrate. Problem with the cortex, you decorticate, arms up. Problem with the brain stem, you decerebrate, arms down. So if you had a choice to come in the emergency room unconscious, would you rather come in like this or like this? Like this. Tell your family members, no matter how they find you, crack your arms up. Just crack them up. Put them up like this, tape them, scotch tape them, do whatever you got to do. Make sure you arrive like this. Because if you come in the emergency room unconscious doing this, the organ people will be after you. They'll be whipping out all your organs. They'll be peeling your skin, whipping out your eyeballs. Make sure it was coming like this, all right? Very good. Other things you need to know. You got 2 holes in your head. Some people got more, but you can start off with 2 holes in your head. You're very happy to have them holes in your head. You know why? If your brain's designed to swell, it goes down them 2 holes. Because if you didn't have them 2 holes in your head, if you didn't have the tentorial notch, the hole, they call it a notch, or if you didn't have the foramen magnum, if you didn't have them holes in your head and your brain decided to swell, where would it go? It'd be squeezing your eyeballs out of your eye sockets, it'd be coming out of your ears, and no one would ever go in your room. Except for male nurses. they would go in. That's the difference between a male nurse and a female nurse. Listen to me. We had some guy come in the emergency room, a patient. He was on his roof, like 2.5 stories up or whatever, drinking beer. Hello. And he fell backwards and impaled himself on a white picket fence. All right, look, all the women are like, ugh. Anyway, so when he comes in, he's, still on the fence. All the females run in the corner like, oh, 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 oh. All the male nurses are like, hey, John, check this out, man. Check this out. They got all the guys around. It's like, hey, how you doing? You all right? Look, how you feel all right? There's all the females like, ooh, ooh, ooh. He wound up being fine, though. He fell like 30-something feet backwards, drunk, impaled him. Yeah, that's the key word here, drunk. Yeah, that's why he was drunk. Yeah, impaled himself. His intestines were fine, his stomach was fine, diaphragm was fine. The only thing he did was like tear an omentum or some little tissue somewhere. Why? Because he was drunk. God has a special place for drunk people. Drunk people, drug addicts. He just looks after these people, right? Me or you, we hold down 2 jobs, we're crossing the street, bing, we die, we get hit by a car. You're going to figure it out. I don't get it. I don't get it. We just had another guy, drunk out of his mind, walking down Highland Boulevard, very big street in Staten Island, gets hit by a car. Well, gets hit by 2 cars. Gets hit by 1 car, flies in the air, lands on another car, flies in the air, lands on the 3rd car. He's fine. The 3rd car he landed on, he went through the windshield, killed the driver. All right? I tell you, when your number's up. She was probably holding down 2 jobs. She probably had 6 kids. You know what I'm saying? And here, bing, bing, bing. The key word, drunk. My next life. My next life. All right, so anyway, so talking about these holes in your head, you got the tentorial notch and you got the foramen magnum. Now, all the nursing books tell you that you're to call the doctor immediately when the brain comes down through the foramen magnum. Now, I wouldn't call the doctor. I mean, your brain is leaving your head. I'm thinking you need to call a funeral parlor. You need to call for flowers. There are other phone calls you need to make besides calling the doctor, okay? Other things you need to know. You got pyramidal tracts. Pyramidal tracts start on your head on one side and cross over in your medulla and go down the other side of your cord. So the pyramidal tracts start on one side, go down, cross over in the medulla, and go down the other side of the cord. So the pyramidal tracts that are on the right side of your head control the left side of your body. And the pyramidal tracts that are on the left side of your head cross over and control the right side of your body. So you're very happy about having pyramidal tracts. Why? They make you move. Pyramidal tracts make you move. Now, if you got a boo-boo pressing on your pyramidal tract, you're going to get a Babinski. Boo-boo, Babinski. Right? So that's easy. Boo-boo, Babinski. So if I have a boo-boo on the left side of my head, I am going to get a Babinski in my right foot. Boo-boo, Babinski. Boo-boo, Babinski. Babinski. That's where you take someone's foot, take your pen, scratch the bottom of their foot, and their toes fan out. Then about an hour later, you got the pen in your hand, you're like, what do you want to eat for lunch? What should we order for dinner? You want to get pizza? We had pizza last night. Let's get Chinese food. You want Chinese food? I'll take it. It's like, hello? If someone shows up with bilateral Babinski, where's their boo-boo? Both sides of their head. Very good. Tell you, it makes you want to go into work, doesn't it? No? Why don't you start a business? Why don't you start a business on the side? Make yourself $400,000 or $500,000 a year. And when you go into work, you walk different. You walk completely different. You're making $400,000 or $500,000 a year. You don't think you'd be going. You definitely want to go to work because you want to irritate people. All right. And you definitely be walking different, right? You're making $400,000 or $500,000 a year. If you're going into work. Your supervisor's like, Mary Lou, is that a hoop earring in your ear? They're addressing some very vital issues in nursing practice. You're like, boo, leave me alone. I'll supply the block that the hospital's on and you'll be working for me. Yeah, I'll give you an idea. I retired from business, so this is the only company I have. But years ago, I used to have a company called Save Your Baby's Life Video. And all I did was I sold videos, and you would make it into a DVD, on how to do CPR on, infant, or I think it went up to 1 year old. And I stopped doing it once they changed the compressions and all. I said, I'm too old for this. So I don't do it anymore. But anyway, all I did, and it don't cost any money to do it. I mean, you just go get a camcorder. If you don't have a camcorder, you have a credit card. All right, you take your credit card, you go to Best Buy, buy the most expensive camcorder. There's one there for $4,000. You buy it, take it out of the box, keep the box. Use it one time, put it in the box, and you return it. Hey, don't worry about it. Don't use it once. All right, so all I did is I got a camcorder. I went to the hospital. It was a Saturday night. I was waiting for the ambulances to pull in. And I, took pictures of that, right? Near, near, near. That's how it started off. Then the second shot was, I went over to my sister's house, and she has pictures of all the kids. And if they stop that construction, I'm losing my patience. Okay? And they have pictures of all kids and whatever. And so it was near, near, near. Each year, thousands and thousands of children die because their parents did not know how to save their life. And then I just, I had a doll. I forgot my mannequin at home. And so I just took a doll and I would, this, and then I think I did unconscious obstructed airway. Anyway, it was, 15 minutes. The whole thing was a 17-minute video on how to save your baby's life. And I sold it to maternity stores and I sold it to hospital gift shops. Now, to get that duplicated cost me $2.35. You would only want a quarter because you're doing the DVD. But the video was $2.35 to get it duplicated in a nice box, shrink wrapped. Okay. And then I sold that to hospital gift shops, and I sold it to maternity stores for $8. And they would sell it for $29.95. So they make a $21 profit. Now, if it cost me $2.35, and then you figure money to ship it out, my cost was $3. And I would sell it to them for $8. So I made $5 on every video that I sold. I was in 200 maternity stores throughout the United States, which isn't a lot at all. I'm not computer savvy at all. So the only way I got the names and addresses of maternity stores is I'd be traveling. Let's say I'm in Chicago, Illinois. I'm in my hotel room. I get the phone book. I look on the maternity stores. I rip the page. I'd be in Columbus, Ohio. I get the phone book, turn to maternity. I rip the page. And that's how I got the names and addresses of maternity stores. But if you're computer savvy, you can go online and get the names and addresses of all the maternity stores in the United States. And there's over 10,000 of them, okay? But I was only in 200, right? I was only in 200 maternity stores. And they sold anywhere from 5 to 10 videos a week, right? They sold anywhere from 5 to 10 videos a week. Now, if you got 200 maternity stores selling anywhere from 5 to 10 videos a week, 200, let's say times 5, would be what? 1,000 videos a week. And 1,000 videos a week at $5 profit would be what? $5,000 a week. So you're pulling in $20,000 a month. And then I was in 183 hospital gift shops. Since I'm bad with math, let's just say 200 hospital gift shops. Now there's over, 9,000 hospital gift shops, all right? But I was only in 183 of them. But let's say 200 because I'm bad at math. So 200 hospital gift shops, and they would sell anywhere from 5 to 10 videos a week. Because see, whenever you go into a hospital, right? Whenever you go into a hospital to go see someone that just had a baby, you walk into the lobby and what do you say? Gift! John, we need a gift! So you go into the hospital gift shop, and what better thing to buy a new mom and dad other than a video that says, save your baby's life. And so they would sell anywhere from 5 to 10 videos a week. And so if you have 200 hospital gift shops selling 5 videos a week, that's 1,000 videos a week, so another 5,000 a week. So you're pulling in 10,000 a week. You're pulling 40,000 a month. That's not bad, right? Why don't you do that? No? All right, never mind. Let's study and get our CCRN credential, okay? Anyway. Here we go. All right, let's continue with neuro, but let me just make sure the construction, it will, neuroanatomy. Let's talk about the third cranial nerve. Now, the third cranial nerve goes to your pupil, but you have other things besides the third cranial nerve going to the pupil. You got the sympathetic nervous system and the parasympathetic nervous system that innervates your pupil. What happens is the parasympathetic innervation of your pupil innervates that pupil and makes your pupil pinpoint. So the parasympathetic innervation of the pupil makes the pupil pinpoint. The sympathetic innervation of the pupil starts in the medulla, goes up through the pons, and innervates the pupil and makes your pupil dilate. The parasympathetic innervation of the pupil makes your pupil pinpoint, and the sympathetic innervation of your pupil makes your pupil dilate. So your pupil does whatever it's supposed to be doing, not only because of the third cranial nerve, but because of the parasympathetic and the sympathetic innervation of that pupil that makes your pupil do whatever it's supposed to be doing. Okay, so it's the third cranial nerve along with the parasympathetic innervation and the sympathetic innervation that makes your pupil do whatever it's supposed to be doing. Let's talk about the person that falls on their head. You know, if you ever want to go clunk your head, try to clunk over here, the front or the back. Stay away from the sides. Why? The weakest part of your head. You know, the weakest part of your head is right where the parietal temporal lobe meets. And right at the weakest part of your head, you have what's called a meningeal artery. And the meningeal artery will, break if you hit your head over here. So this is the weakest part of your head, yet you have an artery there. Very bad construction. So let's talk about the person that falls on the head. If you fall on your head and hit over here, you may have an epidural bleed. That epidural bleed is going to cause an expanding mass. And that expanding mass is going to shift your brain over laterally. The lateral shifting of your brain and your head is known as an umbilical herniation. Right? The lateral shifting of your brain and your head is known as an umbilical herniation. Can you just stop that tape? Someone has an umbilical herniation, their brain is shifting laterally. The lateral shifting of your brain and your head is called an umbilical herniation. And the first change you get is a change in the pupil. You get a change in the pupil on the side of the boo-boo. So when someone has an epidural bleed over here, you're going to see a dilated pupil over here. Your pupil will get dilated, okay? Hey, where did you get a Babinski? Opposite side, right? Look, hey, doc. Oh. Excuse me, doctor, we have an ipsilateral dilated pupil and we have a Babinski on the right foot. Now, and where did we go to medical school? I didn't have to. Sometimes I'm like, why, where did we go to medical school? You're like Harvard. I graduated in 72. I was a physician for about a year. I didn't like it. Very political. Didn't have time to do the kind of caring I wanted, so I went on to nursing school. No. Don't talk back, all right? They'll accuse you of having a bad attitude. So anyway, getting back to the brain, when you have an umbilical herniation, you get an ipsilateral dilated pupil. You get a dilated pupil on the side of the boo-boo. And you don't get any change in level of consciousness. The patient knows, who the president is, the date, the time. They're good like that. They just show you an ipsilateral dilated pupil. Now, when you have people who have an umbilical herniation, you cannot give them any kind of mannitol. These people should not get mannitol because mannitol only works on good tissue. Even though you learn that mannitol works, you learned in nursing school that mannitol shrinks swollen edematous tissues. I think that's what we learned. Mannitol shrinks swollen edematous tissues. No, it doesn't. Mannitol only works on good tissue. And mannitol working on good tissue has a lot of good tissue to work on. And by working on that good tissue, you're going to shrink that good tissue and you're going to allow more room for this to bleed into. So no mannitol, right? No mannitol for these people, right? None whatsoever. And then, of course, if it can't go over anymore, then the whole brain will come on down. Now, when the brain is coming on down, right? When the brain is coming on down, that's known as a supratentorial herniation. That's when the whole brain is coming on down. That's known as a supratentorial herniation. When your whole brain is coming on down, you will get a change in the level of consciousness. Initially, you get a change in the level of consciousness. Right? So initially, you get a change in the level of consciousness. Then you're going to knock off the what do you call, the parasympathetic innervation of the pupil, thereby leaving on the sympathetic innervation of the pupil. So after the change of level of consciousness, you're going to have dilated pupils. After the dilated pupils, then you're going to get hyperventilation. So let's take it from the top. With a supratentorial herniation, you get a change in the level of consciousness. Then you get dilated pupils, both sides, because you knock off the parasympathetic innervation of the pupil. Then you get hyperventilation, because the patient wants to put itself in an alkalotic state. Why? To decrease the ICP. And then after that, you get Cushing's, and I'll talk about that in a minute, but that's the last thing you get. So you get a change in level of consciousness. Now, you're supposed to measure the change in level of consciousness by looking at the Glasgow Coma Scale. Now, I don't know about you, but I don't like the Glasgow Coma Scale. To me, it's the most stupidest thing in the world. I mean, in a report, someone will say, oh, he's like, he was an 11 on the Glasgow Coma Scale, and now he's a 12. What does that mean? I mean, is he dancing now? I mean, you know, what are we doing? You know, or you tell me he was an 11 and now he's a 10. All right, I know he's doing worse, but I don't know what to expect when I go in there. So I don't like the Glasgow Coma Scale. But anyway, it's on the exam. So the Glasgow Coma Scale measures eye opening, right? Eye opening, motor, and verbal. Has nothing to do with pupils. You don't even need a pupil. The fact that your lids are up, you get a good mark, all right? So it's eye-opening, motor, and verbal. Now, I don't like the Glasgow Coma Scale for several reasons. Reason number one, you're giving people points for not doing anything, right? The guy's just lying there, ain't doing a darn thing, you're giving him 3 points. I don't like that. And then I don't understand the Glasgow Coma Scale. I'm giving someone a 3. Inappropriate words. What are we talking about? Bad grammar? Dangling participles? Foul language? What are we talking about here? So I don't like the Glasgow Coma Scale. To me, it's the most stupidest scale in the world. I'll give you an example. We have EMTs that work in our emergency room. And I like EMTs, I do, when they're on the highway picking up bodies. As far as working in the emergency room, I don't like them. They annoy me. They walk around, they got these belts, got these big belts. They got everything on their belt. These leather belts with these metal hooks. They got a pediatric ambu, they got an adult ambu, they got flares, they got an endotracheal tube 7, 7.5, 8, 8.5. They have ABD pads, they got 1-inch tape, 2-inch tape, 3-inch tape. They got a lot of keys, they got flashlights, they got the jaws of life, they got suction. I mean, they're walking around, they're jangling, they got patches all over the darn place. They just annoy me. Anyway, they were just annoying me one night. So they filled the syringe up with water. I said, get out of here, I'm going to kill you, okay? They'll clean your bus. I think it's dirty, okay? All right. So they left, and then they came back an hour later with a dead man. Now, I thought they went down the street and dug him up. Because see where my hospital's located? The hospital takes up the whole block, okay? And then you cross the street, and there's a cemetery. And then across the street from there is a funeral parlor, and then a florist. It's like one-stop shopping for all your healthcare needs, okay? So I figured they went down to the cemetery, dug him up, and brought him in, because I'm from New York, and our sense of humor is different, okay? But they didn't dig him up. They found him behind the hospital. But he was dead for a long, like I thought, a year, but the coroner only said 1 week. But still, he was dead, okay? So they bring him in, and they're doing chest compressions. Guy's been dead for a week. They're like, get a suction, get a suction, get a suction, get a life. What are you out of your mind? Man's been dead for a year. And I don't want to be gross or anything, but when you're outside and you're dead, you don't look good, you don't smell good, your eyeballs dry up, they turn into 2 little peas in your eye sockets. It's disgusting. And they're trying to bring him back. I'm like, get off of him. Even if you did bring him back to life, you won't even be able to see where he's going, right? Get off of him. So then the assistant director of nursing for the emergency room in the outpatient department, she used to be a psych nurse for 13 years. Now, I don't want to talk bad about any group of nurses, but between me and you, psych nurses, even when you're in nursing school, you knew who was going to be a psych nurse. And I was like, hello? Hey, there's something wrong there. But anyway, so they plucked her out of the psych unit. She has 13 years experience. They took her out of the psych unit and put her in charge of the emergency room. They made assistant director of nursing for the emergency room and outpatient department. Get a life. Anyway, so she's in charge. So anyway, she comes up to me and she wants to know how he's doing. Right? The man's been dead for a year. She wants to know how he's doing. And whenever she talks to you, she stands like on top of you. She's like on top of you. She's like, her breasts are smashing yours in. That's how close she stands. Whoa. Don't they learn like personal space 101 in psych nursing or something? Is she blind, deaf? What's the issue here? Anyway, she's right on top of me. She's like, how's he doing? How's he doing? How's he doing? How's he doing? I just step back. Then I figured, let me play with her head a little bit. So I did that word salad. You know that crazy people do? They just like rhyme. I'm like, da 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 da. She's like, Miss Gasparis, I will ask you one more time, and you answer in a professional answer. You know, just give me direct commands, because that's what you're supposed to do to crazy people. Give them direct commands. So I'm like, he's dead. How's he doing? He's dead as a doorknob. He's been dead for a year. Miss Gasparis, I will ask you one more time, and you will respond in a professional manner. I'm like, you know what? You're in charge of the show. You tell me how he's doing. I gave him a 6 on the Glasgow Coma Scale because his eyes were open. So I had to give him a 4. And then he wasn't talking and he wasn't moving. So he got a 6, which is not a bad score to get, seeing as you were dead for about a year. So anyway, so I told him, I said, you know what? You're in charge of the show. You tell me how he's doing, all right? I gave him a 6 on the Glasgow Coma Scale, and he's asystole on the monitor. So we stopped the taping, asystole on the monitor. And then she says, are they going to scan him? Guy's been dead for a year. Said, I don't know. I'll look for insurance card. If I find one, we'll take him for an MRI. And then I had an audience. I had, I had the ME. I had police. I had like an audience. And then I took her by a cheek and I said, and Mary, if you behave yourself, we'll let you take him home. Because you need to be with a man, but it has to be a dead man, all right? Anyway, so I don't like I know, I'm from New York. We're all rude. So I don't like the Glasgow Coma Scale. Why? Because even dead people get a good mark, all right? Now, in order to get promoted, nurses must have a 4, 6, 1 on the Glasgow Coma Scale. All right? 4, their eyes are open. 6, they obey all commands. And 1, there is no verbal response. And in that way, you can get promoted, all right? So you see, I don't like the Glasgow Coma Scale. If I have a gun, it's like a bad day at work. All right, supratutorial herniation. Let's talk about that. That's where your whole brain is coming on down. When your whole brain is coming on down, you get a change in the level of consciousness. Then you get hyperventilation. Then you get Cushing's. This means your brain is leaving your head. It means your brain is coming down through your foramen magnum. It means the party is over. That's what it means. When people have Cushing's, what you'll see is an increase in your systolic BP, thus giving you a widening pulse pressure. You'll get 120 over 70, 160 over 70, 200 over 70, that giving you a widening pulse pressure. It also gives you a decrease in heart rate and respiratory rate, and that's known as Cushing's. And the only thing that might work is if you have mannitol ready to go. If you got to get the doctor, write the order, go over here, get this, forget it. If it's ready to go, there might be some hope. And only if there's some good cells in the guy's brain. Because if there isn't any good cells, mannitol is not going to work. Because mannitol only works on good cells. It does not shrink swollen, edematous cells, even though they taught you that in nursing school. They did, though. They taught you a lot in nursing school. They taught you how to wrap the washcloth. You learn that? I'm like, what, are you out of your mind? There ain't no washcloths in the hospital. Where do you work? All right, so that's Cushing's. And that's a very bad thing. The only thing that may work, again, is mannitol, and only if it's ready to go. When you have someone increase intracranial pressure, stay away from acidosis. Acidosis increases their ICP. Keep them alkalotic. Stay away from hypotonic solutions, because where do they go? In the cell, right? Young kid comes in the emergency room, 9-year-old boy, very bad diabetic, comes in every month with DKA. And that's because his mother doesn't want to keep him on a diabetic diet. Apparently, in the state of New York, this is not a form of child abuse. When I become president of the United States, people are going to have to take an IQ test before they're allowed to reproduce. You take it in high school. You fail, I give you like metal underwear, and that's it, okay? And you keep taking the test, and when you pass, we take it off, okay? All right. I'm not offending any religions by saying that, okay? All right. Anyway, so 9-year-old child comes in every month with DKA because his mother doesn't want to keep him on a diabetic diet. This 1 month he comes in, not with DKA, he came in with head trauma because he took his bicycle, tied it to a car, because he wanted to see what it's like to be on a motorcycle, not like having parental supervision, and he falls off the bike, hits his head on the curb, he's got an epidural bleed, he's got cerebral contusion, big time cerebral edema. ER doctor says to me, "Oh, diabetic child, diabetic child." I'm like, "Very good, Einstein. He's only been coming in every month for the last 9 years. Diabetic child, you give 2.5 dextrose. You give 2.5 dextrose." So I say to him, I said, "Listen, it's a very lucky day. You know why I'm here? I'm a nurse. I'm going to prevent you from killing the kid. Wait, let me make a phone call. Just a moment. Brenda, it's Gasparis. I'm in the ER. I got a murder going on. 9-year-old boy. Get down here now." So I say, "Listen, it's a very lucky day for you. You know why I'm here? I'm a nurse. I'm going to prevent you from killing this kid. See this IV bag, 2.5 dextrose? Read this. Can you read? Good. Good start, eh? Check out the 6th line. It tells you the osmolarity. The osmolarity at 2.5 dextrose is 130. It's very hypotonic. You give that to the child, where's it going to go? In his head. So no hypotonic solutions, none whatsoever. No D5W. Also, you want to stay away from any hyperextension, flexion, right? None of this, none of this, none of that, none of that, none of this, none of that. It all increases your ICP. Also, decreased protein intakes. Stay away from that. You got to feed people. People have to eat. Although it's hard, right? We never feed people in the hospital. Never. You give them those cans of beige, dirty water. Has no nutritional value whatsoever. Coca-Cola has more calories. Give them a can of Coke. It'll make them burp. Things will get moving here. Anyway, decreased protein intake. So you got to feed people, very important. And wrist restraints. Stay away from wrist restraints. They increase your ICP. I mean, if you have to restrain somebody because they're going to pull out an endotracheal tube or something, there are so many humane ways of restraining people. I mean, I go to Toys R Us. I buy sock and boppers. I buy a case of sock and boppers. It's like a beach ball. You usually fill it up with the oxygen on the wall. It's a beach ball. Has a hole in it. They put their hand in it. Has like a little Velcro over here. So if they hit you, you know, some patients hit you, it don't even hurt. They wallop you, it don't even hurt. They get range of motion and everything. It's a win-win situation. All right, onward. They always have one question on cerebral perfusion pressure. Always one question on cerebral perfusion pressure. Cerebral perfusion pressure. The normal cerebral perfusion pressure is 70 to 95. The normal cerebral perfusion pressure is 70 to 95. Now, how you get a cerebral perfusion pressure is you have to subtract the ICP, intracranial pressure, from your mean arterial pressure in order to get the cerebral perfusion pressure. So that if my mean arterial pressure is 80 and my intracranial pressure is 10, then my CPP would be 70. So to figure out a CPP, you have to take the ICP from your MAP in order to get a CPP. So that's easy. Very sophisticated. I have to subtract the ICP from the MAP to get the CPP. And the normal CPP is 70 to 95. Good. I say ADH, you say water. Good. Another thing you need to know is basal skull fractures. When people have a basal skull fracture, they'll present with certain signs and symptoms. Initially, people with a basal skull fracture will get black and blue eyes, known as raccoon eyes. Right? Raccoon eyes. They'll also get black and blue on the mastoid bone, known as battle sign. They'll also leak cerebrospinal fluid from the ear and the nose, otorrhea, rhinorrhea. And they lose cranial nerve number 1. Right? Lose cranial nerve number 1, can't smell anymore. When you leak from the ear, it's usually bloody. So how do you know there's cerebrospinal fluid? Take that blood, put on a gauze, watch for a clot with a yellow ring around it. Cerebrospinal fluid in there. When you leak from the nose, the cerebrospinal fluid is clear. So how do you know that it's cerebrospinal fluid as opposed to nasal drainage? You dip it for sugar. Because cerebrospinal fluid has 60% glucose, whereas nasal drainage doesn't have any glucose in it. Thank God. Think of all the kids picking their nose then. You never get their fingers out of their nose. So people with basal skull fracture get raccoon eyes, battle sign, otorrhea, rhinorrhea, and they lose cranial nerve number 1. That's easy. All right, next topic. Bacterial meningitis versus viral meningitis. Always one question on the exam on this. When you talk about bacterial meningitis, it's from a staph problem usually. And when you look at the cerebrospinal fluid, the protein level is very, very elevated. The glucose level is very low. Apparently bacteria have a sweet tooth. The drainage is purulent. The cerebrospinal fluid is purulent. It's not clear. And there's leukocytes that are present. When someone has viral meningitis, it's usually from an enterovirus or a herpes virus. There is an elevated protein level in the cerebrospinal fluid, although not as elevated as when it's a bacterial meningitis. The glucose level is normal with viral. The glucose level is normal with a viral meningitis. And that's what they like to ask you on the test. That with bacterial meningitis, the glucose level in the cerebrospinal fluid is low. With viral meningitis, the glucose level in the cerebrospinal fluid is normal. So what they're going to ask you is, what's the glucose level in the cerebrospinal fluid when someone has a bacterial meningitis, and you would say it's low. How easy is that? When you have a viral meningitis, the fluid is clear and there are some lymphocytes. When people have meningitis, excuse me, whether it be viral or bacterial, they will get a headache. They will get a stiff neck known as neutral rigidity. They give you what's called Brudzinski sign with meningeal irritation. Brudzinski sign, that's where I take the patient's chin, I put it on their chest, and both their legs fly up. So you got to get out of the way. Could be a job hazard. And then Koenig sign. Koenig sign is another indication that there's meningeal irritation. Koenig sign is where I take the patient's leg, I extend it up, I extend it out. And when I'm extending it out, he gets pain in the hamstring, but everyone gets that. But they also get pain in the neck, right? Koenigs, right? Koenigs. So people with meningeal irritation get neutral rigidity, stiff neck, Brudzinski, bada boom, and they get Koenigs. Good. Seizures. When someone has seizures, subjective data, if you're able to get any information from them, precipitating event. The patient have a fever, does he have an illness? Site of origin. In other words, where did the seizure start? Duration and frequency. Loss of consciousness, was there any? Does the patient have any seizure history? Is it congenital, metabolic, or neurological abnormalities are present? Did the patient have any recent trauma? Pharmacological history. When you talk about the assessment, the objective data, physical examination of the patient during and after the seizure. Note the duration of activity. Was there a loss of level of consciousness? What kind of motor activity took place? Was there eye deviation? Many times if there's eye deviation during a seizure, it'll point to where the problem is in the head during a seizure. You look towards the boo-boo. Incontinence, was that present? Does the patient have a temperature? Post-ictal state, what did the patient look like after the seizure? Did you notice any weakness of a limb? And that's known as Todd paralysis, and it will resolve on its own. And is the patient complaining of a headache? When someone having a seizure, here's what you got to know. Padded side rails, stretcher straps. I have never seen a stretcher strap. Have you ever seen stretcher straps or bed straps? I never saw that, but apparently they must have it somewhere because it's in the core curriculum. No oral temps, suction, and airway set up at bedside. This is common sense. Neuromuscular disorders. Now, according to the new exam, if you look at the blueprint, they have myasthenia gravis and Guillain-Barré. Okay? In talking to people that took the exam, since the new one came out, there has been no questions on either one of these topics, myasthenia gravis or Guillain-Barré. Years ago, long time ago, when neuro used to be 29%, right? Long time, back in the 70s, and some of you weren't even born. But anyway, Really, some of you weren't even born. But back in the 70s, when the CCRN exam was out, some of us old people were taking it back then, and neuro was 29%. It was tough, let me tell you. But some of the topics they asked on was Guillain-Barré and myasthenia gravis. So I would tend to think if a question would resurface, since the pathophysiology of the disease has not changed, either one of them, that it would be very similar to what they used to ask. Myasthenia gravis is an autoimmune attack on the neuromuscular junction postsynaptic defect. In other words, if I can explain to you that you have a nerve, and your nerve will release acetylcholine, and acetylcholine goes on your muscle and will make your muscle move. And then for your muscle to stop moving, the anticholinesterases will eat up the acetylcholine, so then you will stop moving. AACM believes, because there's all different theories, but according to the book put out by AACM, they tend to believe that the problem with myasthenia gravis is a decreased number of acetylcholine receptor sites at the neuromuscular junction. In other words, the nerve releases acetylcholine and there's not enough receptor sites. And because of that, you get weakness. And because of that, you don't move too good. So that's what is believed by the core curriculum put out by AACM. But, you know, a lot of theories, they either think it's too much anticholinesterases that eat up the acetylcholine. Some books say you're not producing enough acetylcholine. So there's all different theories. So the core curriculum that AACN has out says that myasthenia gravis is a result of a decreased number of acetylcholine receptor sites at the muscle. Okay. It's a chronic disorder of neuromuscular transmission characterized by abnormal muscular fatigability brought on by activity, and the key word here, improves with rest. So when you're taking care of someone with myasthenia gravis, you have to give them frequent rest periods. You don't want to get them out of bed, wash them up, give them breakfast, you want to do everything all at once. You just, have to allow for frequent rest periods in between. But the key thing here is their weakness improves with rest. That is very important. People with myasthenia gravis, weakness of the eyes, they can't keep their eyelids up, and then they see double vision. Then they have difficult swallowing, so you got to be careful. They could choke. Hoarseness, limb weakness, and respiratory difficulty and failure if it gets really, really bad. But the key nursing thing here is it improves with rest. People with myasthenia gravis, problems here. People with myasthenia gravis, some of the precipitating factors that put them into a myasthenic crisis would be they're not taking enough medications. Or maybe they are. Maybe they are taking enough medications and they got the flu or pregnancy or menstruating. Maybe they're under stress. Maybe they're going for surgery. There are some drugs that can put people into a myasthenic crisis. If you have myasthenia gravis and I give you procainamide, quinidine, quinine, gentamicin, it interacts with the mestinon as if you never took it. So somebody with myasthenia gravis, be careful. Be careful. You really can't give them any aminoglycosides such as gentamicin, can't give them procainamide, can't give them quinidine or quinine such as a gin and tonic, unless you don't like the bum. Yeah, you've been married to the bum for 30 years. It's been an awful marriage. Just got diagnosed with myasthenia gravis. How sad. Honey, let me make you a gin and tonic. Here. No, you would never. I tell my husband all the time, we lie in bed, I'm like, be careful, be very careful. I have a lot of information in my head, all right? It's awful. But anyway, no. So myasthenia gravis. The treatment, manage ventilatory failure if they have it. You can give steroids, meticulous nursing care. How you diagnose myasthenia gravis? Sometimes they give Tensilon, 2 milligrams IV, and all of a sudden the patient's dancing. Or you give neostigmine. And the nursing diagnosis, impaired physical mobility, ineffective breathing pattern, potential alteration in nutrition. The thing to remember here is improves with rest. Their weakness improves with rest. And the other thing to remember, no aminoglycosides, No quinidine, quinine, procainamide, no, no, no. Be careful with barbiturates and narcotics just because they're very sensitive to it. All right, the next one we're going to do is Guillain-Barré. Guillain-Barré, okay, let's talk about this one. Acute onset due to antibodies directed against peripheral nerve components with a subsequent demyelination, which begins in the distal nerves and ascends symmetrically. In other words, Guillain-Barré, what happens is the myelin sheath that covers a nerve gets destroyed. And when you lose that myelin sheath around a nerve, there's loss of conduction. That's what Guillain-Barré is. It's interesting. MS is the same thing, Multiple sclerosis, same thing. It's a demyelination of the nerve, of the substance around the nerve. Only it deals with the central, whereas Guillain-Barré is peripheral. But it's the same thing. The myelin sheath is destroyed, so you lose conduction. And it interests me so much because people with Guillain-Barré will get better. 3 weeks, up to 3 weeks to 3 months, they will get better because their body regenerates that myelin sheath again. People with MS are unable to regenerate that myelin sheath. I really think the answer to multiple sclerosis, MS, I really think the answer is looking at Guillain-Barré, because whatever the body has to do to regenerate that myelin sheath, I often say, God forbid I get diagnosed with MS, I'm going to tell somebody to inject me with Guillain-Barré. And then when my body regenerates the myelin sheath because of that Guillain-Barré, regenerates that myelin sheath around my peripheral nerve, maybe it'll regenerate the myelin sheath around the central nerve, and my MS will go away. My brainstorm. I don't know, I have to find time to act on it. Anyway, so the problem is the myelin sheath of the peripheral nerves is destroyed, and then you get loss of conduction. Some of the causes of Guillain-Barré, it could occur after a respiratory infection, upper respiratory infection. Epstein-Barr virus can do it. Some bacteria in your bowels could do it as well. Vaccinations can do it. Hepatitis can give you Guillain-Barré. HIV can give you Guillain-Barré. The initial findings, here's what you got to remember. Weakness, it starts in the legs and it moves up. So the key word here, something they're going to ask you on the exam when they do decide to ask you a question on it, is ascending paralysis. Ascending paralysis, and then when you get better, it's descending. So the first thing that got bad is the last thing to get better. So it's ascending paralysis, and then all of a sudden you start getting better, you get off the vent, you're breathing on your own, and now you're moving your legs. So ascending paralysis is the key thing here. Treatment of people who have Guillain-Barré, management of ventilatory failure, meticulous nursing care. My goodness me. Meticulous nursing care is very important. Okay. Psychological support, prevention of deep vein thrombosis, nutritional support, especially because these patients also are dysphasic. How do you confirm Guillain-Barré? Cerebrospinal fluid has high protein levels, and you see a lot of nursing diagnosis associated with people with Guillain-Barré. Powerlessness, disturbance in self-concept, alteration in tissue perfusion, potential for infection, impaired mobility, ineffective individual coping, alteration in cardiac output, and alteration in nutrition. All right, let's do some questions. Watch how smart you are. The single most important index of neurological state is always going to be your level of consciousness. If the question is specific and says something about an umbilical herniation, then you would say change in the pupil. But in general, it's always the change in the level of consciousness. Quick rotation of the head back and forth while holding the eyes open, causing the eyes of a comatose patient to rotate opposite the side towards which the head is turned. In other words, this is so confusing the way to explain it. You have a patient, you lift their eyelids up, you got to make sure they're unconscious. Conscious people just don't want to cooperate. You lift their eyelids up, and you turn their head from side to side. And you'll notice that No matter what way you turn their head, they're always looking at you. Their eyeballs return to midline, right? Ma, 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 ma. That's why they call it doll's eyes. Doll's eyes. Oculocephalic reflex. It's a good thing to have doll's eyes. It's a good thing to have your eyeballs moving in your eye sockets. That's a good thing. Means you have brainstem integrity. Maybe you don't have an ounce of integrity anywhere else in your body, but the fact that your eyeballs are moving in your eye sockets is a good thing, okay? Just got to make sure whenever you're doing that doll's eyes or oculocephalic reflex, you have to make sure they don't have any cervical neck injury. It'd be a horrible thing. You'd be like, hoo, 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 shoot, shoot, shoot. You're like Jen. We had 3 patients come in. Which is the one with the C3 break? This lady over here? Oh, I'm so thirsty. I'm going to go get a Diet Coke. You want one? No, you wouldn't do that. All right, so the oculocephalic reflex, doll's eyes, it checks cranial nerve 368. 368. Doll's eyes are great. Kernix, yay, Budensky. That's it. In the middle of the exam, when everything's really quiet, stand up and say, 368. Doll's eyes are great. Kernix, yay, Budensky. And then sit down. Tell them you have that tic de row, or Tourette's, or whatever you call that disease. Tell them you got some kind of disease. Tell them you have a disease. How come this is not? Okay, oculocephalic reflex. Very good. All right, let's do another question. The response elicited when the neck is flexed, producing flexion of both thighs at the hips. Yeah, Brudinsky. Kernig's sign is where, right, I take your leg, I extend it out, and you get pain in the hamstring and in the neck. Babinski, that's where I scratch the bottom of your foot and your toes fan out. And the Trousseau sign is where I put a cuff on your arm, I pump it up, and I keep it pumped for like 5-10 minutes so that your arm's going to fall off. And right before it falls off, you go like this. It means you have a low calcium level. Be better off getting the blood work done. It comes back faster. The respiratory pattern seen in upper brainstem lesions. Right, if you got a problem with the midbrain, you hyperventilate. Problem with the midbrain, you hyperventilate, blow off your CO2, put yourself in an alkalotic state to decrease your ICP. You see that apneustic breathing? People that apneustic breathe, right? Apneustic breathing, people with a pontine infarct do that. If you got a Pons problem, you apneustic breathe. You see, Pons has a P in it. Apneustic has a P in it. Pinpoint pupils have a P in it. So people with a pontine infarct have pinpoint pupils and they do apneustic breathing. Apneustic breathing, that's breathing long pauses in between inspiration and exhalation, right? Very long pauses. So what happens is the patient's lying there, they're like, and you're like, uh-oh, that doesn't sound good. And you're like, hi, hello, hello? And you're like, put the slide rail down, get the ambu bag, call anesthesia, ready to save his life. He goes, Put the ambu bag back, up at the slide rail. Never mind. And you're watching him. Come on now, hello, hello. You know, so it's like long pauses, inspiration and exhalation. It's like, you know, so just intubate him. 26-year-old male is complaining of a headache, severe headache. On assessment, he has neutral rigidity, all right, and Kernig's sign, which means meningeal irritation. Which of the following conditions most likely present? Well, if he has a headache, neutral rigidity, Kernig's sign, he has meningeal irritation. And what would give him meningeal irritation? Subarachnoid? Hemorrhoid. Yes, a hemorrhoid. I can't come into work tonight. I have a subarachnoid hemorrhoid and it's killing me. No, hemorrhage I meant to say. That'll get the nursing department talking. The classic cardiovascular signs of increased intracranial pressure, known as Cushing's triad. What's Cushing's triad? Decreased pulse, increase in your systolic BP, and a widening pulse pressure. Right? That's known as Cushing's. And that's the last thing you do before you die. Ventricular fluid pressure is the most sensitive indicator of increased intracranial pressure. The normal ventricular fluid pressure is 0 to 10. Good. What's the normal CPP? 70 to 95. Good. Patient has a subarachnoid screw inserted to monitor his ICP and his CPP. Now, the ICP and the CPP are both 35. Well, 35 for ICP is too high, and 35 for a CPP is too low. So what does it all mean? It means cerebral blood flow to his brain has markedly decreased. So there ain't no blood getting up to the brain. So then you have cerebral edema. Your ICP is increased, and your CPP is decreased. Which of the following parameters are greater when using the Glasgow Coma Scale? And you would say it's eye-opening. Has nothing to do with pupils. Eye-opening, motor, and verbal. Glasgow Coma Scale. Blindness of 1/2 of both visual fields following a CVA. Homonymous homoniopia. Yes, homonymous homoniopia. Homonymous homonygnosia. You know what that is? Inability to identify objects placed in your hand. You don't know what you're holding. Very dangerous for girls. Not a good disease to have, you know. Not a good disease going out on a weekend with that disease. Patients, hang on to this. No, only joke. Patients with injury to the left cerebral hemisphere. Patients for injury to the left cerebral hemisphere. Right? You would get right-sided weakness, right-sided hemiplegia, right-sided hemiparesis, right-sided homonymous homoniopia. And your eyes always look to the boo-boo. Yeah. Hey, what's going on over here? Good. So deviation of eyes to the left. Good. Pinpoint pupils that react to light if you view with a magnifying glass. See, now I got to look for a magnifying glass. I mean, I'm running around looking for a flashlight. Now I got to look for a magnifying glass. Pain in the neck. And what? I work the night shift. I don't have to worry. But what if I'm working the day shift? What if the guy's near the window? The sun's shining. I got a magnifying glass. I'm checking the pupils. I'm like, what is that smell? I'm like, whoa, sorry, don't worry. You got another eye. Anyway, pinpoint pupils. And you would think pons, right? Pinpoint pupils. Pontine infarct. Apneustic breathing. See all the P's in there? And you get pinpoint pupils because when you have a pontine infarct, you lose the sympathetic innervation of your pupil, thereby leaving only the parasympathetic innervation of your pupil. So the parasympathetic innervation of your pupil makes your pupil pinpoint. So people with a pontine infarct have pinpoint pupils and apneustic breathe. The nurse caring for a patient with a supratentorial herniation understands that the earliest sign when your whole brain is coming on down is change in a level of consciousness. So you're going to see things such as lethargy and stupor. Let me ask you something. Would you rather be stuporous or obtunded? If you had a choice, what would you rather be, stuporous or obtunded? And you would say, I'd rather be obtunded. Far better to be obtunded than stuporous. Even though obtunded sounds like the last thing you do before you die, it's better to be obtunded. Because obtunded, O, comes before S. If you have two patients and they both look dead, but they're not because they're breathing. You go up to the first lady, she looks dead, but she's not because she's breathing. And you're like, hey, wake up, wake up, wake up. She opens her eyes. You're like, what's your name? She looks at you and says, Mary Smith. Boom, she goes out. She's obtunded. You go to the second lady. She looks dead, but she's not because she's breathing. You shake her. Hey, what's your name? And she's like, she's gobbling. Stuporous people gobble. Obtunded people speak. You work with obtunded people. Just remember that. Which of the following treatment modalities would the nurse consider to be inappropriate? Inappropriate with someone on a ventilator would increase intracranial pressure. Well, if you're on a vent and you have increased intracranial pressure, I want to keep your CO2 low. I want to feed you, right? I want to feed you without a doubt. And I want to log roll you. I don't want to give you D5W because where's it going to go? In your head. Good. While assessing the laboratory data of a patient with head trauma, which finding necessitates the notification of a physician? Well, the serum osmolarity 275 is normal. Sodium level of 138 is normal. That specific gravity of 1.005, that tells me he has diabetes insipidus. Good, learning has occurred. And the urine osmolarity of 400 is normal. 400 to 1200 is normal. A basal skull fracture affecting the middle fossa would cause which of the following? If you have a basal skull fracture, do you lose cranial nerve number 1? Yes. Do you get battle sign? Yes. Otorrhea, rhinorrhea? Yes. So the answer is all of the above. Good. What should the nurse do when his or her patient with a basal skull fracture begins to have clear fluid draining from an ear? And no, it's not D. Hey, get me a yank hour. There's something in there and I got to get it out. No, you want to apply a loose sterile dressing and call the doctor. All right, call the doctor. To determine if bloody head drainage contains cerebrospinal fluid, a nurse would put on the gauze and observe for a blood clot in the middle with a yellow ring around it. Good. Examination of cerebrospinal fluid and bacterial meningitis will reveal all but which of the following? Well, bacterial meningitis, definitely going to be cloudy, definitely going to get increase in WBCs, definitely going to have increase in pressure and a decrease in glucose, that's for sure. You don't get C. You don't get a decreased protein, you get an increase in protein. Which statement is accurate regarding the differentiation of cerebrospinal fluid in bacterial and viral meningitis? Higher level of protein seen in bacterial meningitis than viral? Yes. Low sugar content seen in bacterial meningitis, usually normal in viral? Yes. Cerebrospinal fluid is purulent and turbid in bacterial, may be clear with viral? Yes. So the answer is all of the above. Good, good, good. Care of the patient with myasthenia gravis would include administration of anticholinesterase medications on time. Yes. Scheduling activities in the morning to avoid fatigability of muscles. You can do that as long as you allow frequent rest periods in between. And administration of steroids. That can help as well. Yes. And Guillain-Barré syndrome usually can occur after a viral infection. And it's with the peripheral nerves. That's easy. So now what we're going to do is we're going to go eat lunch, all right? And when you come back, we have GI and renal. So I'll see you back at 1:30. Enjoy your lunch.